Okay, well, I appreciate the opportunity to participate today. I chair a department that has a large genetic diagnostic lab, and we do a lot of genetic testing, including exome sequencing, so I have that conflict to reveal. I wanted to start by thinking a bit about the future of reproduction in this new era, and I think I'd like to sort of make the case that the DNA sequencing regarding a birth maybe should be done prior to conception and prior to birth, and that one can know a lot about the inherited risks to a fetus as well as de novo risks to a fetus with today's technology. There are a number of companies, but probably the most widely known is called Counsel, that is offering very extensive carrier testing to the population. More and more people who are receiving high quality of care are being offered this kind of testing. It's often covered by insurance. And so Counsel is, I think, the highest volume provider, to my knowledge, of a more complex test. And they're doing about 120,000 samples per year. You could think about there are parents of 4 million births per year. And they are increasingly covering huge numbers of loci, as you'll see a bit more in a second. This is another slide from Counsel. It talks about them offering 59 diseases that involve shortened life expectancy, 78 with limited to no treatment, and so on. And so there's quite a lot of heterogeneity here. Most of the disorders that are currently being screened through newborn screening are being tested here with some fraction, sometimes a very high fraction, sometimes a moderate fraction of at-risk couples being identified. This is just one page out of about 20 pages of the disorders that are covered by these kinds of companies. Here we have Counsel has a test they call Counsel 93. There's a Kingsmore published procedure of this type, and there's a company called Inherigene 165, and there are more that I don't have on here. You see things like the human beta-globin locus, cystinosis, and the great majority of newborn screening disorders would be covered by this kind of testing. Also, there's a lot happening in non-invasive prenatal diagnosis. I think this is a real revolution, and I think it's still barely begun. There's reference to non-invasive NIPT for non-invasive prenatal testing versus non-invasive prenatal diagnosis, with some question about what is a screening test and what is a diagnostic test. Many people will be well aware that there's extensive trisomy testing now available with multiple commercial companies, and interestingly, no academic provider of this kind of testing. Current testing is using cell-free DNA and is therefore relatively limited because the DNA is 90% maternal and 10% fetal, roughly. We're very committed to using fetal cells in the future with the idea that one could recover 3, 4, 5 fetal cells from the mother's circulation. One can then amplify each of these cells independently and barcode them and detect not only inherited mutations, but even detect de novo mutations if you have 3 or 4 cells and you consider only those mutations which are present in all of the cells and absent in the parents as being de novo mutations. So I anticipate that we are going to be seeing the sequencing of the genome of all fetuses in the first trimester using non-invasive prenatal diagnosis. And I personally think the resources are much better spent to sequence at this time than to sequence in the newborn period. If you have complicated genotypes, you can prepare for them, you can research them, you have weeks and months to prepare, and in the case of devastating phenotypes, parents have the possibility of terminating pregnancy. So as background, as I think I've already said, almost all disorders currently detected by newborn screening could be anticipated prior to conception. There are some exceptions, such as hypothyroidism, various de novo mutations, such as a DiGeorge deletion, which might show up as a screen for immune deficiency, or a Duchenne muscular dystrophy mutation, and of course congenital infections would usually not be relevant here. So if you look at the amino acid disorders, I think that these tests that are coming forward are going to have in the vicinity of 95% detection for many of the loci in terms of identifying carrier-carrier couples. There's a full range from all the various metabolic disorders to endocrine to deafness to hemoglobinopathies and cystic fibrosis. So one way to think about reproductive risk perhaps is to divide it into those that are inherited and those that represent de novo mutations. If you go to the inherited section first, you are now in these kinds of universal carrier testing where you're testing for many, many recessive risks, but you also can test for certain kinds of X-linked risks, and you can test for certain dominant mutations as well. For instance, if a parent has a BRCA1 mutation, they might be interested in not passing that on to their child. But for the purposes of newborn screening, the autosomal recessive is the biggest group. On the de novo side, you can't find these mutations until after conception, so you're talking about a requirement for non-invasive, for prenatal diagnosis, and I think the future is non-invasive prenatal diagnosis. And you are looking for both de novo CNVs, like those that cause a condition like DiGeorge syndrome, and you're looking for de novo point mutations, such as those that cause disorders like Cornelia-de-Lange syndrome. I apologize here that I have some screen that keeps popping up. So in my opinion, when we take a child with a fairly significant phenotype in the pediatric environment these days, about 20% of them with various birth defects and other disabilities, intellectual disability, about 20% of these we can identify an underlying abnormality with chromosomal microarray analysis, and about another 30% with exome sequencing, and we still have about 50% today that are unsolved. These are for relatively severe phenotypes. I just want to quickly show one microarray in a sample of a child with a deletion of involving the neurofibromatosis region and multiple genes in that vicinity. This is the whole genome display, and the deletion is here. And this is, I hope you can see my pointer on the screen. This is a Y chromosome polymorphism. If we zoom in, we can now see all of chromosome 17. You can see the deleted region, and now you can see individual oligonucleotides in the normal copy number region through the deleted region and back in the normal copy number region. And this kind of analysis is quite helpful in detecting children with the kinds of phenotypes depicted in this figure. These are individuals who had abnormalities that would be detected by arrays, but were not detected by karyotype analysis. So certainly array analysis of the fetus on a routine basis in all pregnancies is one option that I think is very attractive for the future, assuming it can be done with non-invasive samples. And then there's whole exome sequencing. I think the audience will be familiar with this, since this is a big topic of the discussion for today. But I just take this photograph as a disorder that was only described about a year ago involving mutations in ARID1B, and you see here very large numbers of children with this disorder that have a de novo point mutation that also could be detected if one was able to do this genome exome sequencing, say, in the first trimester rather than at the time of the newborn. So if you start with the couple that plans ahead and seeks universal carrier detection, what I call plus being that maybe there's other genotypes that they would like to know about, that they might be relevant to their own health and might influence whether they would want to consider not passing them on. And again, I would say a BRCA mutation would be a good possibility that could be present in either parent. So if it's preconception, they could use preimplantation genetic diagnosis, which I think is particularly attractive for dominant risks where there's a 50% chance that each fetus would be affected. And in this way, whether it's dominant or recessive, they can have healthy children who don't have the inherited combinations of genotypes that they're concerned about without any termination of pregnancy. Now, of course, if they're already pregnant or if you're worried about the de novo kinds of events, you're turning to prenatal diagnosis, where there is the option of termination of pregnancy or early prenatal or postnatal treatment. And maybe in the context of today's discussion, time to work out what this genotype really means significantly before the birth of the child. I don't see newborn screening going away by any means. I don't see these kinds of prenatal and preconception testing becoming universal in the near term, but one will see the newborn screening functioning as something of a backup, no matter how extensive these kinds of tests are, I think. I've mentioned PGD for anyone who might not be familiar with it. It stands for preimplantation genetic diagnosis, so a couple desires to avoid an inherited genotype in their offspring. A dominant BRCA mutation or a recessive cystic fibrosis risk would be typical. In vitro fertilization can be performed. You can grow the embryos to 3 to 5 days. Increasingly, they're grown to 5 days and frozen before reimplantation. You can genotype individual embryos with arrays or with sequencing and only implant embryos that don't have the genotype that is considered to be undesirable. Now, if they're already pregnant, the preimplantation genetic diagnosis option is gone, and you're left with prenatal and the various pathways that are associated with that. So options of the kinds of testing that can be conducted prior to newborn screening are universal carrier detection, preimplantation genetic diagnosis, first trimester non-invasive prenatal diagnosis, and selective termination of pregnancy, early prenatal or postnatal treatment or further diagnostic evaluation. And a major question about what the options are is whether there's already an existing pregnancy. Of course, the preconception options are no longer available. It is important to think about the difference between inherited and de novo mutations. Basically, inherited mutations you can test for in the parents prior to conception and anticipate possible combinations that might result from conception. Whereas de novo mutations can only be tested for after conception and in the prenatal arena. Theoretically, one could perhaps do preimplantation genetic diagnosis for all human reproduction, but it seems hard for me to imagine that that would ever be the case. In the case of severe phenotypes, again, you have these options of termination of pregnancy and various forms of treatment. So abortion is kind of a last resort, I think, on the part of any couple, but in the event that they're carrying a fetus with Tay-Sachs disease or a DiGeorge syndrome deletion or lethal osteogenesis imperfecta, or Duchenne muscular dystrophy or cystic fibrosis, some families may consider this option. I think a thing that's going to be increasingly popular is to identify new mutations in fetuses where both parents have a genotype that doesn't allow you to anticipate this new mutation. The parents have relatively normal genotypes. Virtually all of Rett syndrome can be detected this way, lethal osteogenesis imperfecta, many skeletal dysplasias, lethal skeletal dysplasias, and a number of intellectual disability disorders such as Angelman, types of cases of Angelman syndrome, Cornelia-de-Lange syndrome, Rubinstein-Taby. I showed you the ARID1B Coffin-Cyrus story, and there are other genes like SHANK3 and the Rexin1 where mutations are reasonably frequent. So we do have some experience worldwide in what happens when carrier testing is widely available. In the case of Tay-Sachs disease, it's led to a dramatic reduction in the birth of affected infants, mostly over the years through carrier detection and prenatal diagnosis and termination of affected pregnancies. But there's also been some selective matchmaking, and some families, I think, could increasingly turn to the option of pre-implantation genetic diagnosis. In the case of beta thalassemias in the Mediterranean parts of the world, there are some countries and geographies where there's been a fairly dramatic reduction in the birth of infants with homozygous beta thalassemia. I don't know what the newborn screening programs should be some source of information as to whether anyone thinks they're seeing any decrease in the proportion of infants born with cystic fibrosis because of the carrier testing that is moderately widely available. Sickle cell anemia, again, I think occasionally couples will take steps to avoid the birth of an affected infant, but I don't think that's widely practiced. And, of course, all of these things depend on new kinds of treatments that make the prospects for an affected individual to have a better quality of life. And now we're seeing, for quite some time now, broader Ashkenazi Jewish testing. And I think that's including things like adult Gaucher disease. So I would say that expanded testing may be preferable prior to conception and in the first trimester. Preconception testing can detect inherited but not de novo risks, and that newborn screening will not go away in the foreseeable future. You can ask whether universal carrier testing will become common. Will we see millions of people undergoing carrier testing? And will this be linked to sort of a healthy exome for a young adult individual? Will any of this be done direct to consumer? Can the cost of pre-implantation genetic diagnosis be justified? I think that the cost of pre-implantation genetic diagnosis, in my opinion, is very attractive for dominant disorders. So if you have a family with, say, a polyposis of the colon mutation, if the parent who has this genotype decides to use pre-implantation genetic diagnosis, this disorder can be avoided in their children and grandchildren and great-grandchildren, and whole categories of disease could be reduced in the population through that approach. And I think non-invasive genomic analysis of all pregnancies for both CNVs and sequencing is something that is on the horizon, but it's difficult to predict how rapidly and how extensively that might occur at the present time. And I'll stop at this time.